Good afternoon, everyone. Welcome to the second annual Doula Day. My name is Tony Gillespie. I am the Vice President of Public Policy and Engagement with Indiana Minority Health Coalition. I'd like to thank our viewing audience for being with us. Last year when we did a Doula Day, it was at the Indiana State House. This year, due to COVID and the pandemic, we are virtual, but we're still live. We are broadcasting from all parts of the country, and that's real. You'll see when you meet our panelists and our speakers that we are all over the place. So thank you so much for being here. The goal for Doula Day is to talk about advocacy, education, and policy, and the important role that doulas play in addressing maternal-child health issues. We know that in Indiana, infant mortality has always been a major issue for the last 20 plus years. I've been doing this work for more than 25 years. I started when I was like 10 years old, so that's why I look so young. But we've been doing this work forever, and infant mortality has always been an issue. And in the last 10 to 15 years, maternal mortality has become an issue in the United States. Indiana ranked 3 last year in the country for the highest maternal mortality rates. Specifically from a racial and ethnic perspective, African American women are 3 to 4 times more likely to die in childbirth, either prenatal, during delivery, or the postpartum period, which covers up to a year. And doulas play an important role in changing those health and birth outcomes. Doulas, trained professionals that are trained to provide support for moms and families, instruction, being attendant in the birthing room, and for some programs, follow mom up to a year. The program that Indiana Minority Health Coalition has in South Bend, Indiana Minority Health Coalition Community Doula Services, we follow mom prenatal, in the delivery room, and then up to the baby's first birthday. And that's to ensure that both mom and baby remain healthy and have smooth transitions. So the first part of the day we will talk about is the policy end of it. That's the piece that I love. And we have with us 2 of our warriors, elected officials in the state part in Indiana, Indiana Senator Jean Breaux and Indiana State Representative Vanessa Summers are with us today. Thank you, ladies, both for being here so much.
You're welcome.
So I want to start with Representative Summers. If you could talk about all the things that you did over the last couple of years in addressing maternal-child health issues, doulas, Medicaid care. You could talk about all of that.
Well, what we find at the legislature, sometimes you have to prime the pump. And when I say that, you have got to give advanced information to what you want to bring to them as a subject matter. So I wanted to deal with maternal health because we know that in Indiana, 53 out of 100,000 African American women are dying just by having a baby. And they're dying from the date of birth to 1 year out. So they still need to have some special services. So education is what you do. So what I did was I started with education with my caucus and then with the whole house about what was happening in maternal health, and started a maternal health caucus where I got, of course, most of the African American legislators to join, and a few representatives, Republican representatives, join. I set that up because I knew that next year I wanted to, this was last year, so this year I wanted to bring a piece of legislation that says that Medicaid pays for postpartum care up to 1 year, because we know that is a very crucial year and they need that postpartum designations with Medicaid to be able to get the services that they need. So that was my idea, that I would come back and get this money for the program and In 2021, it was all gung ho for January, and then December 17th, I ended up in the hospital with COVID, and I was in the hospital with COVID through Christmas and New Year's. One thing about COVID is you have to work your way back up to strength. My strength probably didn't come back until February, so by then we had been in session for a month, and I had not been there because I couldn't get myself together. So I was not able to get the hearing for myself. I was not able to get anything. But I don't know if I want to tell my secret, but I got some things working with the help of the senators on the Senate side. So hopefully we'll be watching that in conference and begging it to stay in, and I will be we also did a toolkit. So we also have a toolkit that shows about what is happening around the country for maternal health. So hopefully that will help me get the money I need in the last days of the session with the help of the senators.
And so some of the legislation that you filed and intended to introduce, what were some of those pieces of legislation addressing
Well,
what?
it was the first one was the postpartum Medicaid for postpartum care. We wanted Medicaid to pay for services for women that are on Medicaid. And what happened is that we are happy with the Biden CARES Act that can happen. We just got to make sure that our state officials trigger whatever they need to trigger to get the money back. So we're working on getting that done. Also, there was one shackled prisoners. I just want to mention that real quick. Shackled prisoners that are pregnant, they are shackled through their delivery. So we are trying to make it so that they are unshackled. The one thing they're not gonna do is run when they're trying to have a baby. So those are one of the things that we were also working on. I was joined by Representative Maureen Bauer from South Bend, Indiana, on that piece. But the climate of the Indiana General Assembly does not afford us the opportunity to have many of our pieces of legislation heard. So we got to find other ways of making headway.
Okay. And just for our listening and viewing audience, we will after today we'll list all of the legislation, all of the pieces of legislation that Representative Summers had available on the IN4Doulas.org website. We'll put that information in. So thank you so much, Representative Summers, for your effort
and for
addressing this issue. Absolutely. Then Breaux. Let's talk about some of the legislation, some of the things that you've addressed over the last 2 years. Let's start with your now historic.
You're kind of muffled, Tony.
Medicaid reimbursement for doula services.
First of all, I want to tell Representative Summers, I don't know what the senators on the Senate side are doing to help you, because nobody said anything to me. So maybe offline you and I can chat. I presume it's sticking something into the budget because it's already come out of the House. So you want us to put a line item in for you. Well, yeah, great.
Yes, I've done that. I've talked to Susan Preble.
Oh, wonderful. She's the one to talk to.
Yes, ma'am.
Okay.
I've done
Well, then I understand why I wasn't aware, but that's because definitely Susan is the one. If you want something done in the budget of the Senate side, you go to Susan. But thank you, Tony, for inviting me to participate on this panel to talk about doulas. You know, I love doulas. I was very unfamiliar with doulas, um, except for a couple of years ago when I finally learned all about them. I learned all I could learn about a doula because I offered legislation in the Indiana Senate to have doulas funded through Medicaid. First, we needed to put a doula framework in place that talked about what a doula would need to have and the training and the certifications and then how that would work with our Family and Social Services Agency. So we put all that framework together 2 years ago in the last budget cycle, and we made a small budget request because we were basing it on the fiscal note that our fiscal folks in the Senate provided, and it was a very meager amount, like $20,000. But even that $20,000 did not get funded in the budget, and I was very upset when I went to the microphone that you couldn't even give me $20,000 for a program that's going to
I
benefit
remember
pregnant
that.
women. Excuse me.
I just said I remember that when you were very emotional when
Yeah,
you
I was
talked to the
very
Senate.
emotional. I was very upset. You know, Tony, I've realized as I get older, I'm emotional all the time. I can't seem to ever stop crying. I feel like Boehner, you know, in the U.S. Congress, who used to cry all the time. But anyway, so this year, because we have the foundation in place, I've gone back and I have actually put in a more what I consider precise appropriation for doulas, and it's actually getting a little bit of review and consideration because the person who designs our budget in the Senate felt so badly that he left out that $20,000. But I told him now he should have taken me up on that because I've come back asking for considerably more in the hundreds of thousands of dollars. And so when it's and I won't tell you the exact amounts because I'll let the budget process work its way through. But even that amount, I met last week with the head of FSSA to number one, let her know that I've put that amount in a request into the budget. And did she think it was sufficient enough? And she said, actually, not. That in order to do a really meaningful doula program, we need to have it budgeted in the millions. And I'm not starting it in the millions or starting it a little less than that, about half of that. Now that I've told you about half of that, but she says she can take that half and certainly roll it into a program, sort of like an initial pilot program of sorts. So it's money that we will find a good use for, and it will be specific to doulas. And if we are successful in getting that money into the budget, which all fingers crossed, I'm feeling really very positive about it. Then the FSSA secretary said that that would be a separate line item. It would not be part of the Medicaid funding for doula. Right now, in order to be reimbursed under Medicaid as a doula with the state of Indiana, you have to be designated as a community health worker, and then you have to be affiliated with someone who has a Medicaid provider billing number and a Medicaid provider entity. So somebody who has that billing number and has a practice with Medicaid. And so that for many people is not what they want. They want to many doulas want to be able to practice independently. So
Right.
this appropriation that we've gotten, if we're able to get it, it will be outside of the Medicaid provisions, and so we will be able to reimburse doulas directly from this pile of money without you needing to be a community health worker, without you having to have that Medicaid provider number. And so, and I asked the secretary, well, how do you come up with a rate? And they said that there's a formula they use based on the service that's being provided and so forth. That they have that all figured out. That they will figure out the appropriate rate. But the beauty is that that money will be able to be used to directly pay doulas who are providing doula services. Now, I don't know how all that will work I think we'll probably still have to work those details out. Tony, I don't
Right.
know how we will, once you provide the services, how you submit your claim or whatever that is. So all of that will need to be determined. But if we could at least put a pool of money that's outside of Medicaid, that will be a good starting point. Now, the director did say that, and has been saying that they are going to try to develop their own category, billing category, just for doulas. They aren't able to do it right now, but that is something that is down the road. So we will stay on top of that. Down the road is probably the next budget cycle, would be my guess. So in 2 years.
Right.
Um,
Right.
and until then, you're still able to, if you are willing to become not only a certified doula, but a certified community health worker, and you're able to partner with a Medicaid provider, or IMHC, I think is perhaps a partner. Are you an eligible partner, Tony?
We're going through that determination now, but yes, we will be.
I think that's a goal that you're planning to do. So there will
Yes.
be opportunities between now and 2 years when we actually hopefully get this so that it's streamlined as part of the Medicaid program. There will be opportunities for reimbursement, and there will definitely be opportunities from this pool of money that's set aside, that we're working on right now. So um, just stay in touch with Indiana Minority Health Coalition. They will be apprised all along the way, all the steps along the way. Once we kind of get all this figured out, and we put a plan in place, they will definitely be apprised, and we'll be able to share that with you. But doulas is something that I think is important. The director of FSSA also said that it's important enough such that they've incorporated it in as part of their My Healthy Baby plan here in the state of Indiana. And that's how she also says that in 2 years, when we get the program set up so that you're able to work independently, it would still also be a part of the My Healthy Baby plan. There will always be doulas that are a part of that plan. And the My Healthy Baby is a navigation plan, but it also now includes doulas. So if you need to find services, doulas will be one of those services listed when you contact the state of Indiana for assistance in pregnancy or pregnancy-related concerns. So that's what we've done to doula, and I'll be happy to take any questions. There's a House Bill 1007 that
Mm-hmm.
I've been working closely on with Representative Vermillion. It's an amazing piece of legislation, although it seems to be stalled at this point because it's asking for $50 million, and it's asking for $50 million to be sort of used broadly in the healthcare space. To allow it's designed to be a grant program. So to allow those individuals who have specific health issues and need
Right.
resources in helping to pay for those, you can apply for this grant, and it will address diabetes and all sorts of other chronic diseases. But what I'm trying to get in the bill, I've been successful in getting language in there. I think I didn't ask for the ethnicity. Well, I did. I asked for race, ethnicity, zip
Right.
code. What I really want is zip codes, because I think we really need to drill deep down into the data to find out by zip code where health issues are
Absolutely.
concentrated, and
Right.
what could be some of the factors contributing to the concentration of those particularly chronic health conditions by zip code. So if we see a number of folks living in a zip code that all have diabetes, is it because there's no access to healthy foods? Is it because there is no access to safe outdoor activities in which to gain exercise? So I really think we need to get it drilled down that deeply. I've also asked that a member of the Indiana Minority Health Coalition and someone from the Fairbanks School of Health, that they be directly involved in developing just what the conditions are that need to be that this money needs to be used to address. Is it cancer? Is it maternity? Is it just what is it? And where is it most, would it be most maximized? Now, I haven't seen, they haven't included IMHC, and they haven't included Fairbanks, and they haven't included zip codes, and the bill seems to be stalled. So I am, Senator Charbonneau and I have been in contact with one another. I think there is a little problem with the funding appropriation and just how the funds are to be used. I think there is some effort to try to maybe redirect some of those dollars to education, which is not what we want those dollars to be used for. So I think there's some haggling going on behind the scenes.
Okay. So thank you. That was a huge update with a lot of great information.
And lastly, no smoking. We were not able to get a smoking tax.
Tobacco tax. Right.
Tobacco tax.
Yeah.
Yeah, smoking tax. Tobacco tax.
So how much of an impact do you think? So we know COVID has been devastating worldwide and certainly taking its toll on Indiana, but we know that there are new dollars coming down the pike. So how much of the reluctance around funding some of the programs that you talked about? So do you think that there's some reluctance because new dollars are coming and let's use those dollars and reserve our state dollars?
Well, I tell you what, I think we're still trying to figure that out. For example, I did put in a request for money to go to IMHC to be used for education of COVID and the importance of receiving the vaccination, education on the vaccination for COVID and the importance of receiving that vaccination, and then money for the administration of the vaccine to individuals, because I believe you have the capacity to do that. And I put in my request the dollar amount that I wanted, but I also told them that I know that within the CARES Act or the American Rescue Plan, that there could be dollars that could be used for that, so that you don't have to use state dollars. But let's make sure we appropriate the CARES Act dollars to this. So either way, I don't care where you get the money from. But yes, I think they're trying to, I think there is that potential overlap of a lot of funding areas. And I do believe that there are a number of discussions going on about how to make sure that we don't use state dollars when we can use federal dollars, or how to use the 2/3 match from the Fed, so that we only have to appropriate a third of whatever the cost is, as opposed to 100% of the cost. So yes, all those discussions are going on right now.
And we're not privy to, we just have to make our requests. And like when I mentioned Representative Bauer, we are going to the agency to talk to them about asking for this money to make sure, all of our bases are covered.
As we learn more about the new money and the dollars that are coming out of it, part of that appropriation does speak to expansion of Medicaid to provide postpartum coverage for a year for women, which is certainly that is a great celebration.
And tell you what, we had appropriated, Senator Melton had made this one of his priorities in the Senate, and we were appropriating $2.6 million for that. Based on what we understood the cost would be. But now, because of Medicaid, Dr. Sullivan said that they will, that, as Vanessa said, as Representative Summers said, the department will have to apply to CMS to get a state plan, to change their state plan. And Dr. Sullivan said that could be done retroactively. So I'm very confident that this is something Dr. Sullivan is supportive of. So I think we can see it happening, but there's still, she said she and her attorneys are still working out all of the potential. But I did learn a couple of other things from Dr. Sullivan. May I share those, Tony?
Absolutely, please do.
I learned my concern were, because I had a bill that didn't get a hearing, but during COVID, they relaxed some of the Medicaid requirements to benefit Medicaid recipients, such as you can use telehealth as a Medicaid patient, which wasn't previously allowed, and you can use your SNAP card to order food online, which was not previously allowed. Those two items are now going to be permanently available to Medicaid recipients, Dr. Sullivan said. And then the last, my biggest concern was that Gateway to Work program, which I've just thought was always a barrier to preventing people from accessing Medicaid benefits and services, and they shouldn't have to jump through hoops to get healthcare coverage. And because that's been contested at the Supreme Court, Dr. Sullivan said she believes that that's going to be out and be out permanently. So those are three good pieces of news, I think, for Medicaid populations.
Those are three great pieces of news. And I think collectively, the work on the House side and on the Senate side, I think you guys continue to do tremendous work. And I think that speaks to, it's very, very much in line of what Indiana Minority Health Coalition, our partner TechServ, and many of the other providers and organizations across the state. We're working towards full implementation of doulas across the state, so that women, regardless of socioeconomic status, race, or ethnicity, have access to that support during pregnancy, and
Tony,
delivery, and postpartum.
I don't mean to interrupt you, but next year, I had a bill this year, didn't get a hearing. I'm going to pull it up again next year, but to allow private pay also, to make sure the private pay is paying for doulas as well.
Right. And that is so important, and I think you'll learn from one of our keynotes, Amy Chen with National Health Law. When we started to do research on the Medicaid issue, IMHC, along with Sunny and her team at TechServ, one of the first things that we were so excited to talk to Amy Chen, and Amy said to us, "Oh, I'm so excited to talk to you guys from Indiana. You guys are doing tremendous work. You are really becoming the gold star around this Medicaid issue for the rest of the country." So so we both were, Sunny and I were in shock. I said, Indiana is becoming a case study. Wow. But I think now, because of the work that you guys have done and what you just shared with us, this is why Indiana is becoming a case study. So you've done tremendous work in moving this concept along, because 5 years ago, we weren't having a doula conversation. We weren't talking about doulas. We were still kind of in the dark about what the intervention, what could we do to really begin to impact healthy birth outcomes in a big way. And doulas are the answer. And so as we work on full integration around the state in both support for Medicaid and reimbursement for private pay, I think we're definitely headed in that direction. So thank you for your work. Thank you so much.
And Tony, if I just may add one last thing, I feel very confident that the state of Indiana will expand Medicaid pregnancy coverage for 12 months. I feel very confident about that.
I think if we capitalize on the work that's been done in the House and the Senate and the General Assembly by both of you ladies and some of the other support and other legislators that have co-authored legislation and supported it. And I think a changing of the guard from a national perspective. We now have a different administration. The candidate, the pick for becoming the director of CMS is someone who has written and spoken extensively about expansion of Medicaid, postpartum Medicaid, and the importance of doulas being part of that maternal child health continuum. And so I know we'll hear more about that later, but I think the stars are aligning, in good policy and good advocacy. To our listening audience, when the opportunity comes, when you're asked to call your legislator or write a letter or show up and show out and share your stories, it's really important that we do that. I think both Representative Summers and Senator Breaux will attest to the importance of voices around the state, us telling our stories, us calling a foul when something is not good, but us really being supportive and being advocates across the board. It really does help change things.
Thank you.
Thank you both. I am going to turn it over to my partner in crime, Sunny Lou Williams.
Thank you so much, Tony. We did have one excellent question from the audience. If we could just rejoin the team very quickly. There's an excellent question on, are BIPOC doulas being included in determining what the rate is going to be from a Medicaid reimbursement side? Have we looked at, please.
So the question is, will individuals who are actually working as doulas be a part of that conversation and determining the rate?
Yes.
I would, my guess from what I heard Dr. Sullivan say and how they calculated, apparently they have a formula that they use for all of the various services, and they take that formula and its related information and put it into their little spreadsheet, and that's how they'll calculate the rate. I didn't get the sense that it's something that is very complicated or that it's very objective. I got the sense that it's kind of a rote procedure, and they have the inputs, but certainly if they're I can certainly follow up with Dr. Sullivan and see if there's a willingness to maybe do a roundtable discussion where we can invite some doulas in and they can explain some of the costs. I can certainly ask that and get that answer to Tony.
Thank you, Senator Breaux. That'd be phenomenally helpful.
That's a great question, and it's really important. And I want to say another thank you for the fact that doulas do not have to become certified community health workers to be reimbursed. That was a big issue because when that discussion ensued, we talked about the fact, okay, doulas are trained, they go through significant time period and investment to be trained and certified, and then to add another certification onto it was just kind of not fair. So I'm glad that's off the table. But the concern about the rate is, especially with the community health worker rate, it was so low. And if that was going to be the reimbursement rate that doulas were held to, as my niece always said, I think that's going to be a problem. That is going to be something that we address. So I certainly do hope that there's that willingness, and we have a great relationship with FSSA, and Dr. Sullivan and her team are really tied into community, and they want that kind of feedback. So I think there will be some opportunities to have some conversations about it.
Well, I will definitely follow up with Dr. Sullivan, and I will let you know, Tony, and you can share that with whomever you need to.
Okay, thank you. Will do. That was a great question.
Excellent, thank you all. We have some additional excellent questions from the audience. I'm going to hold those questions to the upcoming segments as they tie in relatedly. And I'd like to welcome Amy Chen to the video camera here. Amy Chen is a senior staff attorney in the National Health Law Program's Los Angeles office, where she conducts research, advocacy, and education on sexual and reproductive health access and services. Her California-specific work includes insurance coverage for contraception and pregnancy, expanding access to family planning and abortion services, and opposing religious restrictions on reproductive health care. Her national work includes leading the National Health Law Program's efforts around improving maternal health and addressing systemic barriers to comprehensive pregnancy care. She is currently spearheading the National Health Law Program's Doula Medicaid project, which advocates for expanding access to full-spectrum doula care for Medicaid enrollees. Before joining the National Health Law Program, Amy worked at Area Legal Aid in Oakland, California for 8 years, where she provided direct legal services to individuals and families across the San Francisco Bay Area, and advocated on a wide range of issues, including healthcare reform, Medi-Cal, Covered California, and private health insurance. Amy is the mother of 3 children, 2 of whom were born preterm. We welcome Amy Chen with the National Health Law Program to today's Doula Day to share more about her work and very specifically key recommendations for Indiana as we continue this legislative and program design in the state. Amy?
Hi, thank you so much, Sunny. Do I sound okay? I want to make sure my sound is all right.
Yeah, sounds good.
Good. Okay. Hi, everyone. My name is Amy Chen, and as Sunny mentioned, I'm a senior staff attorney with the National Health Law Program, or NHELP for short. NHELP, we're a national nonprofit law firm that works to protect health rights for all, especially low-income and underserved individuals and families. Excuse me. NHELP, here at NHELP, we do our work through litigation, policy, advocacy, and education. We work really closely with legal aid attorneys and health advocates across the 50 states and in Washington, D.C. Thanks again to both Sunny and Tony for inviting me today. It's very clear to me that You all in Indiana have some just terrific champions and warriors with not just Tony and Sunny, but also Representative Summers and Senator Breaux. So I think I'm really excited to be invited here today, really excited to hear and learn more about what is happening in Indiana around this work. So as Sunny mentioned, I'm part of the National Health Law Program's Reproductive and Sexual Health team. My focus is on pregnancy coverage and maternal health, and since 2018, I've been leading NHELP's work around Medicaid coverage for doula care. NHELP's Doula Medicaid project seeks to improve health outcomes for Medicaid enrollees by really trying to help ensure that all pregnant and postpartum people who are enrolled in Medicaid who want access to a doula will have one. As we've already heard from other presenters today, maternal mortality and morbidity is really on the rise here in the United States. Pregnant and postpartum people who are Black or who are Indigenous Native American are at the highest risk of poor birth outcomes. Lower income people are also particularly vulnerable. Doula care has really emerged as among the most promising approaches to combating disparities in maternal health. And we also know that people receiving doula care have enjoyed improved health outcomes for both themselves and also their babies, including higher breastfeeding initiation rates, fewer low birth weight babies, lower rates of cesarean births. Importantly, doulas can also help reduce the impacts of racism and racial bias in healthcare on pregnant people of color by providing just really individually tailored, culturally appropriate, and patient-centered care and advocacy. I want to just take a moment now to pause and just share my own story about how I came to this work. I'm not a doula, I'm a lawyer, I'm a policy advocate. I'm also the mother of 3 children, 2 of whom were born preterm, and had to spend time in the NICU before coming home with me. I had doulas for all 3 pregnancies and through 2 labors. With my 3rd child, she actually came so fast my doula didn't make it to the hospital in time. So I personally know for a fact that while I was in labor with my 1st child, my doula helped me avoid an unnecessary medical procedure. It was an episiotomy that my delivering OB, who was a resident at the teaching hospital where I gave birth, was really pressuring me to do. Now, in the big scheme of things, an episiotomy may not seem like a big deal, but at the same time, we also know that so many times during labor, sometimes one small thing can lead to another, and something that may not have initially seemed like that big of a deal can really have a cascading effect in terms of medical interventions. I myself have so many friends who have had seemingly normal pregnancies, which ended with emergency cesarean births and really traumatizing labor stories. So many that honestly I've lost count. So from that day on, when I was in labor with my 1st child, I have just never stopped being grateful for the support that my doula provided to me in the moment that she did. At the same time, it's also really important to remember that I paid that doula out of pocket $1,500 for her support at my birth. And I paid roughly the same amount for my other 2 doulas. At the time that I gave birth to my 1st child, as Sunny mentioned in my bio, I was working as a legal aid attorney in Oakland, California. And as an attorney providing free civil legal services to low-income clients across the San Francisco Bay Area, it was really clear to me how many of my pregnant and parenting clients could benefit from doula care during their prenatal and postpartum periods and during their labor and delivery. Just a doula, just somebody to be there with them, a trained birth worker to support them through that birth and to advocate for and to advocate for them. Yet, as I mentioned, I paid $1,500 out of pocket for the support of my doula, and this was just not an expense that most of my clients could manage. So when a few years later I came to the National Health Law Program with its focus on health access and services, particularly within the Medicaid program, I knew immediately that one of the things I wanted to work on was on expanding access to doula care, particularly for Medicaid populations. Luckily for me, my direct supervisors were supportive of me doing work in what was at that time a new area for NHELP. That was almost 5 years ago. Sunny, could you share, if you could pull up the Doula Medicaid project page? Thank you so much. So today you can find most of our work around expanding access to doula care for Medicaid enrollees on our Doula Medicaid project page. The URL, which I'm sure we can share out later, is healthlaw.org/Doula Medicaid project. And this is just a screenshot of the page that Sunny's pulled up. So at the Doula Medicaid project, we're really engaged in advocacy work on various fronts, including working with doulas, policy advocates, legislators, and other stakeholders to identify and overcome barriers to really creating a sustainable, equitable, and inclusive program for Medicaid coverage for doula care. Second, educating people about the importance of expanding access to full spectrum doula care, including doula support for prenatal care, labor and delivery, postpartum care, miscarriage, stillbirth, and abortion. And third, information gathering and information sharing with states around the country who have proposed or pending legislation, or in the case of Indiana, passed legislation relating to Medicaid coverage of doula care. Both Oregon and Minnesota have offered Medicaid coverage for doula care for several years. On our Doula Medicaid project page, you can see that we've also been tracking more recent efforts at state legislation. In 2019, we tracked 13 states, including the District of Columbia, that introduced bills. In that year, both Indiana and also New Jersey passed bills relating to Medicaid coverage for doula care. In 2020, there were 16 states that introduced bills. Unfortunately, many of those bills ended up being held in committee after the COVID-19 pandemic really brought the regular legislative session in many states to a standstill. Thus far in 2021, you can see, thanks Sunny, you can see the state bills pulled up there. There are 22 states that have introduced bills relating to Medicaid coverage for doula care, including one bill here in California where I am, for which NHELP is an organizational co-sponsor. So as you can see clearly, this is an area and a topic of growing interest across the country. And, you know, as Tony mentioned, you know, what I said when I spoke to advocates in Indiana, Indiana was only the third state to pass, you know, legislation for Medicaid enrollees across the state. And that is why, you know, I continue to say that Indiana is a trailblazer. You all are implementing something that many states are still in the process of kind of figuring out, introducing these bills. And so I think you will really have an opportunity to kind of lay the groundwork for the states that come after you. In my tracking of the state legislations and in my conversations with doulas and policy advocates in many states, there are a handful of states that I want to just kind of particularly highlight and discuss. So certainly Minnesota and Oregon are worth taking a closer look at. As I mentioned, both states have had Medicaid coverage for doula care for some time, but there have been challenges with implementation in both states. There was a recent series of articles in the Washington Post, which I think we can maybe also share out the link after the presentations today, that detailed how in Minnesota, in particular, the low reimbursement rate and the bureaucratic challenges with billing and reimbursement has meant that many doulas serving Medicaid clients have really felt that they're effectively taking on their Medicaid clients pro bono. So the initial reimbursement rate in Minnesota was $411 for prenatal, postpartum, and continuous support during labor and delivery. This was really quite far below the amount that doulas typically receive for private clients paying out of pocket. In 2019, legislators in Minnesota did increase the reimbursement rate to $770. However, even that higher rate still did not really equitably compensate doulas for the amount of time that they spend with each pregnant and postpartum client. More to the point, data from the Minnesota Department of Human Services shows that between 2014, when the Medicaid coverage for doula care first started, and 2020, doulas provided support for Medicaid enrollees at roughly 850 births, which is a number that seems surprisingly low for a state where 26,000 people each year give birth while enrolled in Medicaid. Meanwhile, in Oregon, the numbers have been even lower, with the Oregon Health Authority claims data recording only an estimated 200 Medicaid births that have been attended by a doula. The actual number of Medicaid enrollees who have received doula services in Oregon is higher than that amount, since some doulas provide services for free and some doulas are being paid to provide services to Medicaid enrollees through other sources such as grant funding. However, the number still really falls short for a program that has been up and running now for over 6 years. In Oregon, the reimbursement rate for 2 prenatal visits, 2 postpartum visits, and continuous support during labor and delivery is $350. I should note, in practice, many coordinated care organizations in that state do pay doulas a higher rate than the standard fee-for-service rate. However, it's still clear that the baseline of $350 per client also does not come close to approaching a real living wage for the doulas that are doing this work. In contrast, a bill that was introduced in 2020 in Massachusetts, but like many bills that I mentioned, was held and did not move forward. It contemplated a reimbursement rate of about $1,500 for prenatal and postpartum support and continuous support during labor and delivery. The Massachusetts Doula bill, I think, was also really notable in that after the bill was initially introduced by the authors in the legislature, the bill authors and sponsoring organizations led by the March of Dimes held a series of doula town halls across the state. And the bill authors subsequently made revisions to the bill language in direct response to the feedback that they'd received at some of these town halls. So I will say that the bill that NHELP and others introduced last month in California that I mentioned earlier was modeled, parts of it were modeled largely on this 2020 Massachusetts bill, because based on our assessment, the language in the Massachusetts bill was really good in terms of being equitable, sustainable, and inclusive, and really good in terms of sort of thinking out, kind of piecing out how they wanted implementation to look like in that state. I know that in particular, this issue about a sustainable reimbursement rate is really going to be a sticking point in many states, including perhaps here in Indiana. So to that point, I do want to point you all to a report published in 2019 called Advancing Birth Justice. This was by two doula groups, Ancient Sound Doula Services and Village Birth International, and by a policy advocacy group, Every Mother Counts. Among other things, the report really helped make the argument for why doula reimbursement cannot be pegged to reimbursement rates for medical providers such as doctors and midwives. So just go back to my own story for a second. When I was pregnant, each of my appointments with my OB lasted maybe 15 minutes each. And yes, for sure, my OB was definitely there at my labor and delivery, but she was only there during the last maybe 30 or 40 minutes when I was literally pushing my baby out. So in contrast, the prenatal visits for my doulas each lasted anywhere from an hour and a half to 2 hours. And not only was my doula with me during my entire labor and delivery, but the doula in particular for my first birth came to my house when I was first starting to have labor pains before I even went to the hospital. And after my OB had finished delivering my baby, clocked out, and gone home, my doula was still there in the hospital room with me, making sure that my partner, my baby, and I were okay. All of which is to say that the amount of time that a doula spends with her client is much more than the amount of time that an OB spends with a pregnant person. Taking this into account, it really makes sense then that the amount that a doula would be compensated for is just different, because the type of care and the time that the doula is spending providing that care is different. It's just a different type of care than that provided by an OB. Secondly, when I was pregnant, I'm confident my OB had dozens of other clients that she was seeing during that same period, whereas in contrast, my doula could only really take on 2 to 3 clients in any given month, just by nature of the fact that she was on call during that period for those births. So again, the nature of the doula's work and how they provide care to those clients also really makes it impossible to peg in any rational way to sort of compensation for medical providers like OBs. So, you know, there are certainly many challenges that Indiana and other states are likely going to face in implementing legislation relating to Medicaid coverage for doula care. Especially challenges in sort of crafting a program that is really equitable, sustainable, and inclusive. These 3 cornered sort of keywords that I keep coming back to. With that in mind, I do want to close with some recommendations. So first of all, I really encourage Indiana to get this right from the get-go so that you all won't have to do a lot of cleanup on the back end. As I mentioned, both Minnesota and Oregon have had to pass numerous bills over the years to fix or improve upon their original legislation, including pretty fundamental changes in some cases to the billing structure and increases to the reimbursement rates. Certainly, you know, we can see that Indiana has an incentive to be thoughtful and to craft a really, again, those words, equitable, sustainable, and inclusive program for Medicaid coverage for doula care from the start. Second, as I think was sort of alluded to in the question that I heard earlier, I really encourage the legislators, doulas, policy advocates, and community members who will be implementing Medicaid coverage for doula care here in Indiana to make sure that at every step in the process, community-based doula groups who are already serving low-income and Medicaid enrollees and who are already serving pregnant and postpartum people who are Black Indigenous, and people of color are really front and center in crafting the policy language and determining how it is implemented. As I mentioned earlier, I'm not a doula. As such, with the Doula Medicaid Project, NF has always sought to do our work in partnership with and with the guidance of community-based doula groups, doula collectives, and individual doulas, especially Black doulas and Black-led doula groups, as well as doulas and doula groups serving low-income clients. Third, as firm as my faith is in the power of doulas to positively impact the lives of their clients, I also know that in the end, we can't put it all on their backs, right? So doulas can help mitigate the impacts of racism on their clients of color by advocating for them in the face of individual, institutional, and structural racism. But at the end, we know that the individual, institutional, and structural racism will still be there, harming other people. Doulas may be necessary, but they alone are not sufficient. So the solution to the underlying racism that really plagues America's maternal health care system cannot be simply throwing doulas at the problem. So as we all do this work, we must remember this, and remembering it, continue to also do work in other ways to seek out and eradicate racism in all its forms. Lastly, whether you're a doula or a legislator or a policy advocate or a community member, just remember what this advocacy is for. As I did when I first started this work, and as I continue to try to do today, I really try to hold close to me the stories of the people who need doula support and the stories of the doulas who provide it. Pregnant and postpartum Medicaid enrollees in Indiana deserve the support of doulas, and doulas deserve to be paid a living wage for providing that support. And message to the doulas of Indiana, please never forget that every day you are doing life-changing and life-saving work. And from someone who has 3 times now seen the benefit of that work, I thank you from the bottom of my heart. Thank you again to Tony and Sunny for inviting me to speak today. I know Indiana can get this done and get it done right, and I can't wait to see it. Thank you so much.
Amy, thank you for your wonderful story and for sharing your top recommendations. We will do a capture of Amy's top recommendations as a summary back out to all of our attendees, but thank you so much for that education on current Medicaid across states and for continuing to reinforce that we are progressing and we're progressing well within Indiana. Thank you so much, Amy. Up next, we have Elon Geffrard, who is a certified birth doula through Doula International, a certified lactation counselor and certified childbirth educator. She finds her greatest joys in supporting her community as a village auntie, serving families as they transition into parenthood and advocating for the inherent right for all families to experience holistic, quality, and respectful care before, during, after pregnancy, and birth. She also is a doula with the Michigan Prison Doula Initiative, serving incarcerated pregnant persons and provides support directly during their labor and birth experience. In 2019, Elon completed the Maternal Child Health Immersion in Havana, Cuba, in partnership with the National School of Public Health and Charles Drew University. She received her formal education from Michigan State University, where she studied physiology and health studies with a cognate in psychology. She is also co-founder of Birth Detroit, an easy access prenatal and postpartum clinic, and soon Detroit's first freestanding birth center. Her passion is driven by the phrase, "We must lovingly hold parents so they can lovingly hold their babies." That is beautiful. Welcome, welcome, and thank you so much for sharing your time and efforts with us today. I'm going to go ahead and transition the presentation screen to you. There we are. And oh, go ahead, please.
No, thank you, Sunny, and thank you, Tony, for the invitation. I'm really grateful to be here. I'm going to share my screen, and for accessibility, I want to make sure that folks can see what I'm presenting, so there will be captions for folks to see. Sorry, it's one of those either or with PowerPoint or webinar. There we go. All right, here we go. And are you able to view?
Looks great.
Awesome. So I am a doula and have been serving as a doula in Michigan for 5 years now. And the work that I have found myself situated in both public health and in community and private doula care has been around how do we transform the systems that care for us. And that's my hope, is to share some of my personal experiences and the things that we're aiming to do in Michigan. So as mentioned, I work with the Michigan Prison Doula Initiative as a birth doula. And it is an endeavor. It's totally supported by donors and lovingly by community, in partnership with, well, to serve the incarcerated folks at the Michigan Department of Corrections. So we only have one women's prison here in Michigan. And the inmates are allowed to choose if they want a doula to attend their births. And that has had incredible response since we actually were allowed into the prison in 2018. Even with the limitations of COVID, we have seen births happening. And if you're a doula like me, we never stopped working during the beginning of the pandemic. And then I was mentioned in my bio around Birth Detroit. We provide not only easy access clinical care, both prenatally and postpartum for families, but we are a midwife-led model, which I think has significant impacts on connecting families with doulas. And we have a small pool of resources where we can give a portion of a doula's fee for their time in supporting our Birth Detroit clients. So why do I doula? I doula because the families and the parents and the babies that I see remind me that I am a part of this community, that individuals who have been turned away from care, marginalized by systems based on their citizenship status, their status as perhaps a re-entered citizen, their status socioeconomically, their gender, all of those things matter. And having support and advocacy, no matter what identities society has labeled you with or what identities you identify with, you deserve someone who will listen to you, believe you, respect your choices and your wishes, and advocate for those. So when I think about the times that we live in, I want to also herald the message that Black maternal and infant health morbidities and mortalities are not news. These things have existed far too long and are a direct reflection of the health of our community. I lift up the message of Black Lives Matter, which is really simply a love letter to let Black folks in particular know that your life is not only important, but valuable and deserves recognition. And so I say that just as kind of the parallel between how policing of Black and brown bodies in the United States has happened over the years, unfortunately, so has healthcare policed the birthing bodies of Black and brown people. And my hope is that when we think about how doulas really show the importance of the future, the thriving of Black and brown bodies, we get to change the narrative and the infrastructures that currently exist around Black and BIPOC health, wellness, and liberation. So I'm focusing my conversation from a doula's perspective on how we get to be a part of moving systems change. The World Health Organization Commission recommends that when we want to do systems change work, we must first improve the living conditions. And I'll share a bit about what is what constitutes those living conditions, or what we've known as the social determinants of health. That's one way that we must improve how systems currently work. So even in that, thinking about sentencing for pregnant people, that's a part of the living conditions. Then thinking about how we tackle inequitable distribution of power, money, and resources, and then measure and understand the problem. And sometimes we can overanalyze and overstudy a problem where we move away from the solution and focus solely on evaluating the outcomes rather than recognizing that the outcomes are perpetuated by systemic conditions. So I offer this framework, as I mentioned before. I work in public health, and so this is how we talk about health inequities and addressing them. So this graphic comes from the Bay Area Regional Health Inequities Initiative. And this kind of shows us where, when we talk about, and I'm so delighted to have heard Amy mention that doulas are part of the solution. We are not the answer. However, when we use what's called a downstream or addressing an intervention, right? So doulas are a part of intervening with the mortality outcomes that we see, the diseases and injuries that show up in the postpartum period and prenatally. I'm going to stop I know that the captions may be misinterpreting my words. So please, just if you can focus, I apologize. It's technology, y'all. So when we think about the downstream effects, like, again, the behaviors we know contributing to individuals' poor health outcomes, thinking also about doulas being a part of that, not only emotional and physical support and advocacy, but also ways of mitigating some of these outcomes. That's actually a systems approach. So when we think about systems and larger upstream issues, that includes not only the living conditions, but those policies. How is policy being shaped in Indiana? So grateful to have had political representatives on the line talking about the work that they're doing. But if we really want to do this sustainably and intentionally, we must really be thoughtful about how the unintended consequences of policy, and also how do these policies impact the outcomes we're endeavoring to change. So race is not a health risk. In obstetric and maternal care, race is often a check mark. It is a screener. It is even listed as one's ability to be successful or unsuccessful when it comes to a vaginal birth, their ability to recover. And so I want us to be clear that doulas are an equity response, especially for Black and Brown people, because it is those systems that we all function in that have been shaped by deep inequities like racism from the inception of this country. So it is important for us not only to elevate that Black and Brown individuals are dying at 3 times the rate of others, but it is also important to herald the importance of Black and Brown advocates, Black and Brown doulas, to mitigate the effects, the many razor cuts that racism does to Black and Brown bodies even before they become pregnant. So again, thinking about how racism shapes the biases that we hold, how it has shaped the systems in which we function, we must be solution oriented at the systems level, and using doulas as a way of addressing this systemic issue is necessary. So we can get into a very complex conversation around race being not biologically real. It is a phenotypic expression of genes, but race is a social construction designed, again, at the inception of this country to allocate and distribute power and to relegate value. But while it is not biologically real, race has very real and negative outcomes. And that is because for some of us, we live in a racialized society that has made our bodies, our beliefs, our experiences invalidated, and those are held in place by racist policies, practices, social narratives, and norms. And so we can conclude again that race itself is not a person's risk factor. Racism is. And we speak again to this, the benefits of Medicaid eligible individuals and the reasons why doulas are so important for those folks. But I want to lift up that being Black, identifying as woman, also increases one's risk, regardless of their resources. I have served women who were CEOs, who were physicians themselves, and still felt marginalized, felt unheard, disbelieved, and felt as though their providers, even the providers that may have looked like them, weren't there for them. And so again, thinking about those individuals who are just as much at risk, this is why Medicaid policy is so important, because the direction that Medicaid goes in is also the direction that most private payers will follow. I lift up the urgency of intersectionality, and this phrase was coined by Dr. Kimberly Crenshaw, who is a lawyer, activist, and a professor who really introduced this concept around these overlapping, overlaid areas where folks experience oppression. And so if we take one's sexual orientation or their gender identity, mix it with their socioeconomic class and other points of identity, and conflate it with race, or cross it with, again, one's race, that we can see compounding effects in their outcomes and experiences, particularly in health and health systems. So I want to guide us to our North Star, because that is, again, one of the endeavors of this work of shifting and changing policy and really giving attention to what is necessary, right? So fair doesn't mean everyone gets the same thing. Fair means I give folks what they need to have just opportunities to be safe, well, and healthy. So I lift up the National Birth Equity Collaborative, led by Dr. Joya Creer-Perry. And their definition of birth equity is the assurance of the conditions of optimal births for all people, with a willingness to address racial and social inequalities in a sustained effort. I add to that definition that when we address the root causes of inequities, which include racism, sexual discrimination, and exploitation, and remove the subsequent barriers and create fair and just opportunities and conditions to achieve optimal wellness before, during, and after pregnancy and birth. So how do we move, again, using birth equity as our North Star? How do we move in the direction of systems change? And systems change has to happen at many different points. It is not a tiered approach. It is a simultaneous collaboration from both policymakers, advocates, and those who are most deeply impacted. So I speak to, again, those who have power in making decisions, that you must first address our own biases and assumptions. What assumptions do we make about doulas? What assumptions do we make about Black women and Black parents when it comes to their birth experience and their feelings of being believed, even in the postpartum period? We must broaden our paradigms and experiences. I love to have heard the senator share that she did not know who doulas were until she got a clear understanding. And sometimes, again, those assumptions can make us believe that, again, doulas are one thing, that all we do is rub backs or hold feet or hold the baby, when in actuality, our work goes much deeper. And so when we're looking to shape policy, create a new world, we have to hear many different experiences to shift our own paradigms. We must challenge dominant narratives and models. For many years, while doulas have existed for a long time, for many years, doulas were considered a luxury to the wealthy, a luxury to those who could afford it, and not considered essential for those especially who have been pushed to the margins during their health experiences. So we must challenge those narratives about who deserves doulas. How much does doulas deserve to be paid? What narratives exist that create a less equitable space for both clients and doula providers? We must trust that people know what they need. I couldn't emphasize more that it is very difficult, and we get this from the American Disability Act, but those in the disabled community mentioned, don't create anything for us without us. If you have never experienced a doula, it's very difficult to always know what doulas do. I always love hearing my clients share back, especially the partner, to say, I had no idea that you did all of this, and you made my experience just as rich as you made her or their experience. And then whenever we create policy, we can't just include community to check a box. We have to share the power and the decision making. In Michigan, I have to lift up the work of Senator Erica Geis, who has been pivotal in bringing this legislation forward over the last year and a half. So that's about 2 sessions. One thing I have to value about this collaboration with her is that she said, what do doulas need? Write it down. We can't depend on bill drafters to solely be the ones to provide the language for what we need to see different outcomes. So this is my dear colleague, sweet baby, Savannah. And sometimes we have to kind of take on the mentality of a child. What if we just asked a deeper why? What if we asked a deeper how? So let's imagine a new way. What does it look like to reimagine maternity care with equity and love at the center of it all? That clients get doulas who speak their language, who identify with them culturally, who can spend time with them based on their life and the cadence of their life and what they need. Providers are more in tune to listen to the needs, and clients and patients feel powerful to share what their experience is like and what they desire it to be. And that even in a pandemic, even with the limitations of coming close to one another, that no pregnant person gives birth or does something very difficult alone. So there are a number of articles that can be shared, and this is actually quite an old one that talks about the impacts of doulas on healthy birth outcomes. We don't need another study. We don't need another research project. We don't need another 5-year program. This needs to be a sustainable budget line if we are to see differences in outcomes. And we know that, again, doulas impact not only the health of the person giving birth, but also creates more opportunities for bonding. So a reduction in postpartum mood disorders, a reduction in an increase in human lactation, which we know is best for babies. NICU stays are abbreviated, again, because parents have the emotional support to be able to sustain breastfeeding and human lactation, which again we know benefits newborns. So if we're thinking, and I'm so again glad that this work is happening in Indiana, and again, Indiana, the Midwest looks upon you, that when you're continuing to develop this intentional legislation, that we must first do so by listening to each other, that stakeholders have a huge part in this, leveraging existing programs and ways of incorporating doula work in what already exists. Listen to the research that doulas do mitigate negative health outcomes, and that together, if we listen to one another, and one of the works that we've been doing in Detroit is to show that we all desire the same outcomes. We just have different roles to play. So if we recognize all of our varying roles, we get to develop a shared vision. Engage people's needs. Again, nothing for us without us. You should engage doulas who serve Medicaid eligible families. I offer pushing back on some of the formulaic constraints and saying, again, looking at the scope and the time investment that doulas do offer families, especially families with more complex social needs and emotional needs, and perhaps some other resource connection that is necessary for the health of that family. Engaging those doulas and really listening to all that they do may be really helpful in shaping policy, especially around equitable reimbursement. And knowing that doulas work, this is their profession. There are many individuals who do this as a full-time job. It is a deep calling for many people. And so in order for us to serve folks in a equitable way, our autonomy should be respected and considered. And again, knowing that we work in harmony with healthcare providers wherever they are in support of that client, not to polarize the room or polarize medical support or healthcare support. And we understand that federal Medicaid guidelines can create constraints. And so we get the ability to be innovative and explore the possibilities within those constraints. And finally, we must act. We must be biased towards action. If you want to do this sustainably and equitably, we must honor the community that is deeply impacted. And that's not just the folks that are working as doulas, but the folks that would need a doula. Once people hear, again, I'm thinking about our incarcerated population, once they heard what we did, they said, sign me up, I want it. And we only could spend a very brief time with them. But even in those brief encounters, we were able to serve and support them in ways that made a very high risk, stressful pregnancy typically less stressful, and that they could reflect on their birth experience with less trauma and more of a joyful celebration, even though they could not be with their babies. We must act to address the immediate need. Another mother, another parent, another baby cannot afford to be lost while we wait. So please consider how quickly we can move to address the immediate need. And then we must plan and build community power in how policy is shaped and implemented. I can't say enough that we all hold and possess individual power, and we must put productive pressure on those who have the ability to make decisions, to not only invite us, but to hear us. And again, we don't have to ask permission to save ourselves and our community. This is within our reach. So I leave you with the words of a Detroit native and doula, Adrienne Marie Brown, from her book, Emergent Strategy. And the quote reads, "How we intentionally change in ways that grow our capacity to embody the just and liberated worlds we long for." We get to be innovative, we get to be creative, we get to be a part of the change that we desire to see in both parents, families, mothers, and babies. Thank you all for your time and attention. I'm going to stop sharing and turn it back over to you.
Elon, that was amazing. Thank you, thank you, thank you. And thank you for naming it, naming this powerful statement that in the face of institutional racism, doulas are an equity response. For all of our state agencies and legislators and government programs that have recently taken on racial equity as a pillar, this is the call to action. It is doulas as an immediate intervention to our most vulnerable populations that will result in healthy, resilient, whole babies, moms, families, and individuals. So thank you, thank you. Across the country, one of the largest institutions is the Department of Corrections. And as Doula Elon has recently spoken about transforming systems through doulas, we are now going to take a snapshot look into Indiana's Department of Corrections. And I welcome Dr. Dauss to join us. Dr. Kristen Dauss is the Chief Medical Officer of the Indiana Department of Corrections. She received her bachelor's degree from Indiana University and her medical degree from Morehouse School of Medicine. She completed triple board residency in general pediatrics, general psychiatry, and child adolescent psychiatry. She is board certified in general and child and adolescent psychiatry overall. Her experience allows the unique ability to examine systems of care and treat the whole person. Her examination of these systems has led her to lead and spearhead innovation and programs of change in the Department of Correction. Dr. Dauss, we thank you for joining us on your vacation. We appreciate you so much for dialing in. Would you take some time just simply to share with us the innovative programs that you have instilled in the Department of Corrections in Indiana in supporting and serving our justice-involved families?
Absolutely, and thank you for having me today. I am so honored to be a part of this, and to hear that last panelist and woman speak was absolutely inspiring. So thank you. This is a very, very timely conversation. The Indiana Department of Correction does intake women who are pregnant. And quite frankly, a lot of times we also take them in as safekeepers from local county jails who may not have the resources to support these women in their care. A lot of incarcerated women, the majority of women who come to us pregnant, are delivering high-risk pregnancies. So this means that these babies typically need additional interventions and specialists to not only monitor the pregnancy, but again, also assist in the delivery and then the care of the infant and mother thereafter. Being incarcerated, being a woman, being incarcerated as a woman and pregnant, comes with a lot of physical and emotional stress. And we are mindful of that. We want to support these women along the way. We want to make sure that they have, that not only them, but their families, their other children back home, have the resources to thrive when they go back out to the communities. So just to share a couple DOC programs that we have, we are going to be dedicating the Brianna Leith Maternal and Child Health Unit on tomorrow, actually. This unit has been in existence for approximately 10 years. However, over the last 2 years, 1.5 to 2 years, it's been under the medical division. And since that time, we've made some drastic changes to the operation, the programming, and all that is provided there. This unit really is a it's a space. It's very different from a typical what you would envision, I guess, as a prison. It's built as a nursery almost, where moms and babies can stay together, where there's toys, where there's all other kinds of activities. We want it to feel very like a home, right? Because it is their home. This is their home. We want to respect that sacred space. We allow in our maternal and child health unit moms to stay with their babies as long as they have no more than 36 months on their sentence. And that really is because we want to make sure that the infant is receiving all the services, all the education, all the programming and milestone development and all those kinds of things while they're with us. And we know that once they start hitting 4 and 5, they really need to go to preschool and start entering that system. So we let them keep them if they have less than 36 months on their sentence. And that was one of the changes since it came under medical. We really have moved to this model of inclusion. So everyone is accepted to the maternal and child health unit if you are come to us pregnant, versus you know, you have to kind of interview and you may be excluded. So within the last year, 80% of moms who have come to DOC pregnant have been able to be a part of this unit and this, I really feel like it's a coalition, a sisterhood almost there with their mom, with the babies. We also, in the last year and a half, have partnered with Eskenazi Health. So previously, moms were delivering at St. Vincent Anderson. So that meant that mom was at Indiana Women's Prison, which is in Indianapolis. She would have to receive OB care and deliver at St. Vincent's Anderson. Okay, and then if baby had an issue, baby was transferred to St. Vincent, Indianapolis. So now you have mom in Anderson, baby in Indianapolis, and we just did not feel comfortable with that. So we now have a partnership with Eskenazi Health, and both mom and baby stay together at Eskenazi. This has really helped in the care because the OBGYN has access to the pediatric records, the pediatrician has access to the OBGYN records, and also we have all the specialists there in-house at Eskenazi Health. In the last couple months, we have had a pediatrician with Eskenazi come on site to the maternal child health unit where we have a clinic now, and all well child checks are done in the clinic. So this means that mom can be there with the doctor and ask questions and learn how to support that child in their housing unit, like kind of where they live. And that too is new because at one point the baby was going out to the pediatrician and the mom was staying back at the facility. So now the mom is part of this process and can be there and ask questions and play an integral role in the care of the baby. In addition to this unit, we also provide all women, but also women who are pregnant or postpartum with behavioral health care initiatives and treatment. So whether that be substance use treatment, we do provide Subutex and MAT for moms who are coming in on those medications. We continue those during the pregnancy and as long as they need them. We also provide mental health treatment. So if a mom were struggling or postpartum depression or lost her child, or in the last year and a half, I think there have only been a couple women who haven't been able to keep their babies. But those women too, we want to wrap our arms around them and support them. So to make sure that they feel included, and we don't necessarily forget about them, right? We want to make sure that their mental health is holding up during that time. We also have community-based providers come in. So we have lactation consultants, we have WIC providers, we have other folks for the baby come in to make sure that baby is getting that educational training and meeting milestones and things like that. So one misconception that I do want to use this time to clear up is around restraints. That is one thing that when I started with the agency 2 years ago, absolutely not. So while we do have to make sure that anyone going off-site, safety and security is maintained at all times, we are not promoting or requiring or advocating for restraints at any appointment and especially during delivery. So we've also changed the policy there that as mom's delivering, restraints are essentially off, or they are off. If there was a reason, that would be a discussion, but ultimately it's the medical provider who has who weighs in there to make that decision. But we are not restraining women during pregnancy. How can doulas be a help? I think just to echo some of the things that I've heard already today, and that's advocacy resources. Again, this is a very vulnerable time for women. And, I know what it's like to deliver. I know what it's like to be a mom, to be a first-time mom, to not know, to be young and feeling out of sorts and relying solely on instincts. And to also be incarcerated at the same time, I want these women to know that their voice matters, that they matter. And sometimes it's difficult for them to speak up, even now, and say, this is what I want. This is what my baby wants. We don't want to squash that voice. We want that voice to be amplified. We had a situation just a couple weeks ago where a mom felt as though she wasn't treated the best way by a healthcare provider, and we encouraged her and we walked her through what that grievance process looks like. And I think that could also be the role of a doula, is to speak up for the mom, to help encourage her, to ensure that she has those options and knows, has that guidance and support during pregnancy, during labor, during birth, and then in that postpartum period as well. We know that these babies are high risk, so we too want to make sure that mom understands and knows the options and has the choices, and we want to make sure those doctors are sitting down and explaining those things, and that the mom feels supported. We also see great value in doulas when it comes to emotional and physical support. We have prided ourselves on the rate that we've seen C-sections decrease. We no longer, gone are the days, and this was happening, where C-sections were planned, so that way the facility knew when to transport and when they were going out and this sorts of thing, and we do not do that anymore. We allow for a normal birth process as much as possible, anytime, whatever is medically indicated and that sort of thing. So C-sections have dramatically decreased. Birth rates are going up. Satisfaction, we want to make sure that women feel satisfied and safe during this time. And then also too, like I mentioned, the postpartum depression and monitoring that. So we just want to make sure we know that when moms feel safe, when moms have their baby, that attachment, that bonding, that security is super important, and leads to success upon reentry back to the community. The final thing that I will share here as well is, while we're working on these initiatives to kind of get in line with community-based standards and almost even expand, right, to support doula services. And our our next medical vendor. Doula services are a part of the care that we want to see provided. So we are doing some things as a state agency to make sure that women have access to the best care possible and support. But then also we are having conversations with our jails across the state and the Department of Health to make sure that women who are in county jails also have access to standard of care. So I'm proud of that initiative. I'm proud of the work that we've done, but I know that there's a lot of work to continue to do, and I'm happy and really look forward to seeing doulas being part of the work that we do within Indiana Department of Correction.
Dr. Dauss, thank you so much for your visionary leadership and for addressing exactly what is needed now and in support of our families that are justice involved. Thank you for your leadership. I'd like to welcome Dr. Dauss, Doula Elon, and also Nurse Yolanda Washington back on screen for a few panelist questions. No worries, Dr. Dauss. A quick introduction of Yolanda Washington. If you don't know her yet, you will know her now. She is a registered nurse from South Bend, Indiana, and she designed the best practices guidelines for the state's first ever funded doula program in collaboration with Indiana Minority Health Coalition. Yolanda Washington has been a key part of hospital system design and core teams of care teams, and dedicated her career to ensure communities are heard within the health systems. So ladies, thank you. And we have essentially created an organic care team this afternoon to hear from our physician, our nurse, and our doula on some of the tactical issues that come about when doulas are probably should have a great promotional banner and sign going into health systems saying, here we are here to care and collaborate. But when we don't have that, there's a lot of lack of education, lack of understanding from the care team side. So our first question is, from your perspective in your scope of practice, what is the greatest benefit that doulas can provide to the care team within a birthing unit? I'm going to go ahead, and I know Doula Elon is like, I know this one. So I'm going to go ahead and kick it off with our doula and followed up by Nurse Yolanda and Dr. Dauss.
We are not here to ever say, don't trust these people. We're actually here to say, here is the thing and that you desire, right? To remind the client, this is something you want, or this was an option we talked about. And to say, these are your partners, talk to them, right? So that's one way we help with communication ease, to bring down sometimes the stress that could happen with miscommunication. Yeah, so we're gap fillers, bridge makers.
I love that. Gap fillers and bridge makers. Wonderful. Nurse Washington.
Hi, everybody. It's so nice to meet each of you, and I thank you for this opportunity. But also, I see doulas as a very integral part of being in the healthcare setting, because oftentimes when nurses are there, they only can provide 6 to 10% of their time to the actual. Where doulas are there 100% of the time. They can meet their emotional needs. They can assist them in whatever it is that needs to be done. And just like Doula Elon said, they're only there to make that connection and help to ease some of the process and be a communicator for the patients on their behalf. Also, our doulas, when nurses have other patients that they may have attend to, that doula there. I mean, she's right there every step of the way, every minute of the way, and she's there to support them, to help communicate for them, and to help them to experience a positive birth experience, and being that mediator between that doctor, that nurse, or whoever else that comes in the room for that patient. So that's what I see them doing.
And that's so important, because if we looking at our data sets with most of our most vulnerable families, they're only having access to prenatal care in the middle to end of third trimester. It's a tremendous amount of prenatal care coordination education that can't just be delivered right there in the birth room. So having doulas provide that support and education is a real wraparound for the entire care team. Excellent points, Ms. Washington. Thank you. Dr. Dauss?
Yeah, I would just echo what has already been said, and I really think it comes to advocacy and just another support and resource. I mean, honestly, as a physician, I took an oath to do no harm, and I think a physician who's committed to that oath welcomes any and all feedback, right? So we want to sit down and we want to hear from the patient. We want to sit down and partner with a doula. We want to hear that voice. We don't want to miss something. I mean, I can't imagine how many times, I can't even tell you how many times a nurse was like, Dr. Dauss, are you sure I want that, right? Because that is what helps us to deliver better patient care. So for me and this huge system, right, we are talking 24,000 incarcerated individuals, right? Almost 800 women. I want to know where we can do better and how we can do better. So I just appreciate, I would love to have that extra voice there to help us do a better job.
Can I add something else as well? Another thing that I just thought is because doulas have a relationship with these moms. As a nurse who's just coming on shift, never met this individual before, and that doula has established a relationship from the beginning or maybe the middle of their pregnancy until that point when they go to deliver. So they have a relationship with them, and those moms trust their doulas. They share so much information with those doulas, some things that doctors may never hear, the nurses may never hear of, but those doulas, they're right there and they know what's going on.
Absolutely, great points. You know, as Dr. Dauss was mentioning, the interest and the inquiry that she has for her patients, I will say that she is a cut above. When we have a system that we are living in today where Black and brown women are not being treated equitably, when race-based medicine is still being taught in our medical schools, to Doula Elon's pivotal point that doulas are an equity response, how can we further empower doulas to be that response in serving our BIPOC communities? What can we do as community, as stakeholders, as coalitions, as state agencies, and so forth? What can we do to help to support and empower the doulas' work as they serve our most vulnerable families?
Well, I'll start, okay? One of the things I see this as, when you look at the concept of mothers giving birth, you have to look at the holistic approach of it. And we are a team. And teamwork, whether you start from the bottom up or from the top down, we are a team that works together. And anytime there's a break in that system, whether we're going from the top down or the bottom up, there's a disconnection or disproportion in that area. So we must continue to work together. We need our legislations. We need our representatives. We need our doctors. We need our nurses. We need our doulas, and we need our moms to help the community or help the world as itself to grow. So education is the key for everybody across the board. And we must remove our own biases, no matter what we have been taught in the past or what we even have been used to. If it's not right, it's out. So we must start with the education.
I'd echo that if we really want to see doulas as a sustainable piece of this puzzle, because we're not the only answer, we need the clinicians to know their stuff and to do their own work about how they're providing care. We need agencies and larger systems to think about it. But I would say that if we really care about this and if we care about outcomes, that we need to put our money where our mouth is, right? I believe we resource the things we care about. So when you look at your state budget, where does a lot of the money go? In Michigan, the Department of Corrections has a huge budget. It actually tops our health department. So that says what we value. I'd also say relinquish control of, like, we can go against models and systems that have valued certain identities and have been, you know, kind of racist. Who does it give the benefit of the doubt to, right? Who has to reap different types of penalties because of who they are, right? Why do certain organizations, why are those certifying doula bodies credible while Black-led or BIPOC-led agencies are not, right? Where does that come from? So if we say we value it, you got to accept the different places that people are coming from and honor cultural experiences. And I would say that, like, I appreciate a percentage back on reimbursement, but $400 nobody can live off of. Right. So if I serve a family for 4 months or even 14 months, if we're talking about the extended postpartum year, $400 for that one client to give them my undivided attention is inequitable. It's unfair. So yeah, putting our money where our values are.
I think that I would just echo the piece too. I mean, both of those pieces, right? And I think this is why we were very intentional about ensuring that there was funding, right, for doula care, because a couple years when I very first started, I think I was maybe a month or two in, so maybe 19 months ago or so, someone came and said, hey, we do a doula program. I think it was Wisconsin. And they said, we have a prison doula program. We want to do something similar in Indiana. And at the time, you know, I had just gotten on the state side, the barrier was funding. So I kept that in mind. And as we went for our next medical vendor contract, I wanted to personally make sure that there was support there, financial support there for doula care and doula services. So yes, funding, and then two, the piece around education. Again, I share these stories not to say, look how great we are, look how, you know, it's more to say, we have done a lot of work, but we still have a long way to go. When that same program came in, there were, you know, facility leadership that was like, we don't want them in here. We don't want them talking to our moms. We don't. And it really was eye-opening to me, I think, because I want them, right? Like if we can keep a mom safe, if we can keep a mom healthy, then we all win, right? But it was education, right? We had to share that story that we're all here, right, for the best interest of the patient. So,
Dr. Dauss, please, Doula Elon.
I just want to first just like, if I could hug you, applaud you, non-COVID, Dr. Dauss, you'd have those amazing perspective. I also want to lift up that there are systems that benefit from certain people being oppressed. Yeah. So we got to go after those things and align with the people who value addressing oppression and addressing the status quo. And you do that, Dr. Dauss. I hope you're so encouraged because you're pressing. We need you in Michigan.
Awesome
report somebody over here, please.
Right. Awesome job. It's just amazing. When I was just listening to your story, Dr. Dauss, it is like, oh my God, like none I've ever heard before. And so we appreciate all that you have done and all that you're yet to do. And we know it's a lot of hard work, but know that we are here to support you in any way that we can help you facilitate that. We got your back because we love our doulas. We love our moms. We love our babies. And again, it goes back to teamwork. Teamwork makes the dream work every time. And anytime there's a break in there, there's a disconnect and we have to get back on track. So awesome job.
Well, ladies, this is the visionary care team that's going to take us into the future. So thank you all for sharing your perspectives, your insights, and your wisdom. We are going to transform, we are going to make change, and we are going to continue to innovate. And so we thank you for participating in Virtual Doula Day. In closing, I'd like to invite Carl Ellison, the CEO and President of Indiana Minority Health Coalition, to join this wonderful visionary team of care team members to share with us the initiatives and appreciation of Indiana Minority Health Coalition for all the stakeholders, community members, and support partners. Mr. Ellison?
Well, Sonny, thank you so much, and thank you all for having me on. I get the great privilege of being on many conversations where women leaders really.
You do.
Kristen knows, if you ever do a vaccine webinar with Dr. Dauss or with Dr. Virginia King or Dr. Lindsay Wells, other leaders, and be the only man on there, it's great. You just gotta sit back and listen. And so that's the way it is today. Just know that as an organization that's been around for 26 years that exists to eliminate health disparities, we do that by being the town crier, by also doing interventions that work. And so as an organization, we're just very, very blessed. Bear in mind that beyond being a minority controlled organization, we actually have trustees like Senator Jean Breaux, and we have a staff member like Representative Vanessa Summers, and we have a colleague like Dr. Kristen Dauss, and I agree with you. Elon, as much as you might want Kristen, we're not done with it yet. And because Kristen has really done extraordinary work in transforming the view of Department of Corrections around health and around putting in place structures to provide health, both while in the walls, and we're going to continue to work with Kristen and the DOC with respect to how you then transform more of this health out to people leaving the institutions and going to the community. Because after all, we don't want them back in those jails, right? But I wish that we had today all the maternal and child health community, all of the state government community, because other years need to hear this. This really wasn't a conversation about doulas, as much as it was a conversation about the need for more will, more effort to address the needs of people of color, disadvantaged population, to make the system, if you will, perform in a more intentional way that's good for us, and it recognizes that the system can do a better job if it just connects with us. And so I think on behalf of our organization, really, it's just such a pleasure to hear Yolanda and Elon and all of you, again, articulate a clear, coherent message about what we need to do. And I think our challenge now is to make sure instead of a few hundred people on the day that we have 1,000 people on the day, or that we find ways to continue to share the message. There's no mystery here. I mean, this is all quite common sense. This is not rocket science. But know that our organization will do everything it can with you to help amplify your voices, and to do it, frankly, in a systematic way where we make some of that good trouble, where people get tired of hearing from us, but we do what we got to do to force systems to accept reality and to be intentional about how they're going to go about assuring that we achieve more equity in health outcomes, and that we provide the support necessary to give everyone a chance to have good health, including those who are incarcerated, those who are poor on Medicaid, whatever they may be, that we do indeed work towards seeing greater human potential realized, not just among people of color, but really among everybody, so that we get to a point where there's greater equality in this society. So thank you so much for being part of this today. Thank you so much for letting us at IMHC help to bring it together. And thank you so much for staying our ally down the road, where, if you know Sonny Lou Williams there, Sonny's not going to let you go once you touch it, right? You know that, I presume. So thank you for being part of our tribe, and we will want to continue to work with you to make sure together we amplify this tribe's voice so everyone can hear it.
That's the work of doulas, Mr. Ellison. Lift up the voice.
Amen. So, Sonny, I guess it goes back to you. That's all I had to say.
Well, thank you, Carl, so much. Your words of wisdom and your continuous support and your energy at the helm ensures that Indiana continues to strive for legislative, education, and programmatic efforts to support our BIPOC communities. So we sign off for Doula Day 2021. We appreciate everybody providing support and attendance and energy today. Thank you to all our panelists, our speakers, and we will be sharing the recording online and also through a social media campaign forthcoming. Thank you all. Have a wonderful day, and thank you to all of our doulas for all that you do to serve our communities and our families. Take care, everyone.